So as Stan knows me well since I was a medical student, and he also knows that when I start to talk about something that I'm passionate about, the risk is giving me a microphone and a set of slides. I will definitely try to control my usual 5-hour diatribe and finish in 45 minutes. Hopefully what will happen is that what we're trying to do will cause you to think and maybe ask questions and give us some advice, because although everything that we're doing at CMU, I believe, has sound evidence to support it, I think it's largely proven practices. I'm not aware of it being put together, things being put together the way that we have, or that we are putting them together. So in order to try to control myself, I'll try to stick to these topic areas. So what are the drivers of change in medical education? Talk about evidence-based, our evidence-based patient-centered curriculum, and then delve a little bit into the issues of specialty choice, physician retention, et cetera, because the challenge that we face in central Michigan, central and northern Michigan, is perhaps a little bit different than the challenge we face in the more urban areas of the state. So there have been legion white papers, articles, et cetera, talking about why we need to change medical education. Obviously, the pace of scientific inquiry. Last year, there were more than 800,000 medical journal articles published. So it has become completely impossible to keep up with the totality of the field, and perhaps for many of us, even within our niche. More public accountability, IHI and others, our wonderful economy, which makes it even more incumbent upon us to be good stewards of the resources. And within that context, obviously, healthcare costs continues to rise. And then specifically the IHI, which Stan referred to earlier, is a call for care that is safe, effective, patient-centered, timely, and equitable. And I added, should be personal, evidence-based, and holistic. And then we need to still deal with our racial and ethnic disparities. There is not equal access to high-quality health care in this country yet. And then a rising burden of chronic illness and disability. Those of us that are baby boomers, I think, know this well. I have been the recipient of a knee replacement and so on myself. So as we started down this road, we did a needs assessment for how one should start a medical school. By the way, if you ask me the question about how does one prepare themselves to start a medical school, the answer still is I don't know. So, but I'm here. So, at any rate, we did, I think, what is educationally the right thing, doing as complete a needs assessment as we could, and we looked at those white papers and the recommendations of the medical education experts. And among those recommendations are, we need to redefine the foundation sciences. So unlike other medical schools, we don't have basic science departments. We have an area of discipline that we call foundational sciences. And in addition to the usual suspects, we include psychology and anthropology and social sciences and so on. And we've added in quality improvement in decision science and epidemiology, where we are giving an equal emphasis to social determinants of health and non-health, which I think is a bit different. So if we take the usual, if we start talking about stroke and MI, and I said to Stan, what are the 5 key risk factors for myocardial infarction, stroke, and he, hypertension, hypercholesterolemia, diabetes, family history, smoking cigarettes. And then you start to think about the social determinants, which are malnutrition, chronic stress, poverty, lack of education, sedentary lifestyle, et cetera, and the variance explained in patients that have myocardial infarctions and strokes is exactly the same. So we can't ignore those aspects of healthcare, and they will not be ignored at CMU. And I'm not saying that they're ignored elsewhere. My perception is that they're not given an equal opportunity. Facilitating problem solving, this is called for by lots and lots of experts, Commonwealth, et cetera. Continuity, a real continuity experience for our medical students, and an emphasis on community-based education, training students and residents in the environment where they're actually going to take care of people. So it is a real environment. Preparing students to work as team members. Fortunately, I think, if not dead, the captain of the ship is dying. I think that's a really good change on our part. Absolute authority when it comes to the care of patients, in my opinion, is not a good place to be. So we'll be selecting students for their ability to work in teams and their interest in being a member of a team, and then training them in a team-based model. Increased knowledge of public health and non-biological determinants. I already made at least some case for that. But in addition to that, population health, community health, et cetera, they're the basis for how we go about assessing how effective we are in our practices. The statistical methods, the question answering methods in epidemiology are the same as answering the questions about how well we're doing in taking care of our patients. And then developing the teaching and mentoring skills of our faculty to make sure that we can deliver the kind of curriculum in the right culture for our students. So the proper learning environment is critical. Fred Hafferty and others have written widely about the hidden curriculum. And for those of you that aren't sure what that is, it's basically the difference between what we say and what we do. So we tell the students that we respect each other, and we respect our patients, et cetera, and then in the elevator or down the hall, we talk about, you know, Mr. Smith, who's a difficult patient. We label him as a jerk, et cetera. Or we talk about those damn surgeons, since I'm an internist. We talk about those damn surgeons and how difficult they are to get along with. And that sends a message to our students and our residents that we probably really don't want to send. Simulation. Anybody in here want to be the very first candidate for an internal jugular IV for a medical student? How come no hands went up? Well, so, you know, and I think back to, you know, growing up in the see one, do one, teach one era, where, well, and my training was in old inner city hospitals, where to some degree our belief was it's better to have at least a medical student than no one. And, you know, we're not going to promulgate that. So we're going to have a very rich, we've designed in Mount Pleasant and we're designing in Saginaw, our other campus, very rich simulation environments that span the spectrum of medical education. So it's for the students, the residents, and the continuing education of our physicians in those communities. And then the integration of instruction. So, and I'll talk a little bit more about our curriculum, but the students will not learn biochemistry as a biochemist. They will not learn physiology as a physiologist or anatomy as an anatomist. They're going to learn these areas in the context of how we take care of patients and why they're relevant to the process of taking care of patients that present to us for either the prevention of illness and the maintenance of health or for the care of their medical conditions. So I believe that one of the keys to being able to control costs and to get us back to a space where we have high-quality physician-patient relationships is a concept labeled the patient-centered medical home. And there's various definitions of this. I think there are principles that apply. I drank the Kool-Aid, so that's my bias. I think that this is the right place to go. A couple of years ago, by the way, I presented the patient-centered medical home for surgeons to the Department of Surgery at Wayne State University and converted like half of the room. So I've counted that as one of my great successes. So in the patient-centered medical home, we view patients as individuals, and we place great importance on the physician-patient relationship and expand it to be the relationship between the patient and the practice team. And I think that's really important because then patients can actually get the care that they need from a member of the team. They don't always have to see the physician. It frees the physician up to do things that physicians only can do. And for those other standardized aspects of care, the patients can get their care there and not be lost in the communication struggles that we have right now. There's also a systematic assessment and improvement of how we take care of patients. So we're measuring ourselves. We're looking at how we and the team do from the perspective of the patient's experience, the process of care, and the outcomes of care and the cost of care. And those are, again, basic principles of the patient-centered medical home. So the idea is to coordinate, so you've got continuous, coordinated, comprehensive care for patients. And it's based upon the trust that grows within that physician-patient relationship. So Carnegie, pooling all this together in 2010, made some recommendations for how the educational system needed to adapt. So we should be creating opportunities for integrative and collaborative learning. So interprofessional education would be one example of collaborative learning. Inculcate habits of inquiry and improvement. So I self-assess, do I have the data I need either from the perspective of the patient's information or from the literature, from experience? And if I do not, then how do I get that information so that we can provide the right care? We need to provide a supportive learning environment for professionals, for the professional development, professional identity formation of our students and residents, a system that advances the health of individual patients and populations. We need to standardize learning outcomes so that if Stan or I are taking care of the same patient, the things that we would do for that patient wouldn't differ. If we're each taking care of different patients, then we meet the needs of the individual. But I think there is enough evidence, in most cases, enough proven practice that the rationale for two physicians qualified to take care of a given patient, the care for that patient should not vary significantly. Integrate formal learning with clinical experience. So you'll see some slides later where we are nesting the actual delivery of the curriculum within a clinical model. If you think about those of us that are physicians in the room, and so I'll talk about my personal experience a little bit. When I started medical school, it was butts and seats. And we listened to a lot of lectures, and we memorized, and then we came back in and took a multiple choice test and regurgitated what we learned. And then in the third year, we started relearning everything we learned in the first 2 years, except to learn it the right way. And the other thing that I came upon, and I've talked to a lot of physicians, I haven't done a formal study, is that when we learned medical information in the context of how we're taking care of patients, it stayed. We didn't have to intentionally memorize it. We didn't forget it. And so why would we not, as we think about training students from day one, why would we not start with that kind of a model, get them engaged and excited about being a physician and what we can do to help people with their health? Developing habits of inquiry and improvement. I've talked about that a little bit, but we need to habitually ask ourselves, can we do better? And focuses on, again, the progressive development of the professional identity. I don't think any of us, I certainly at 60 don't feel that I'm a finished product. I hope I continue to grow and learn and so on for many more years. And certainly as students and residents, they're not finished products. So I'm going to talk about a little bit about the what and hows of this Carnegie recommendation. And this will lead into a conversation about the curriculum model at CMU. So I had mixed feelings when Dave Leach and company came up with the competencies some years ago. I think it's now about 11 or 12 years ago. But they actually provide a framework that allows us to be successful in standardizing learning outcomes. We need, however, enough individualization in the learning process that we can take into account the learning preferences of our students. Because some students are kinesthetic learners, others learn well from books and then modeling, et cetera. We need to provide multiple opportunities. And we need to open up elective opportunities for the students to develop the skills that they individually would like to develop. So you've seen the usual 6 competencies. There was a proposal for a 7th by the previous speaker. At CMU, we've teased out community and population health because we believe that the skill set in biostatistics, epidemiology, continuous improvement, et cetera, are really critical skills, and that we would be remiss if we graduate medical students that are not prepared to work with this knowledge and skill set. So how do we do this? So we have gone through and we've imposed upon ourselves and followed a systematic design for curriculum development cleverly named the Instructional Systems Design Model. If you Google this, if you look this up, you'll find there are a number of these. But the model that I'll show you kind of pulls together the commonalities of the various models. Key is matching the assessments to the competencies. So once we make a statement of what we expect the students to know or to be able to do, or we talk about their attitudes, then the measurement is created. They're all constructs. As you know, there is no way to absolutely know truth. And then we design the instruction toward those measurements and those objectives in an iterative fashion so that we can be as comfortable as possible that we're measuring what we want to be measuring. So that's the validity step. And then over time, we analyze it to make sure that the measures are actually reliable. And again, multiple assessments, multiple biopsies of the student's progress, and multiple methods of learning opportunities for the students. So this is the model. What's in yellow are the assessment or evaluation steps. But again, we do the needs assessment. We looked widely. By the way, the very first thing we looked at, which should be no surprise to anybody in the room, was the USMLE blueprint. Because if we graduate physicians that can't pass the boards and can't get a license, we obviously haven't accomplished anything. We just took that as the bare minimum. We don't think it's sufficient. It's necessary, but not sufficient. And then we looked much more widely, including talking with people that live in our region, physicians that practice in our region, as wide a look at medical literature as we could to make sure that the content was what we wanted in the form of knowledge, skills, attitudes, and behaviors. And then we developed and are continuing to finalize these, a set of objectives that state our expectations for the students. The assessments are well underway to the development, and design the instruction, and then test it. And we're doing some of that right now. So I just wanted to share with you, I won't go into great detail, that this is one of the ways to assure that there isn't consistency. And then integration. So what does integration mean? It's really, there are multiple layers of integration. So in its most simple form, it's connecting formal knowledge to clinical experience. So including early clinical immersion for the students so that the things that they learn in the classroom are reinforced. So continuing with my model of clinical learning, the students will learn in a very rich case model. It's been variously called the patient presentation model. But the idea is that you have a virtual community with a set of virtual families. And the people from those families, which can be as small as N of 1, not knowing any parental heritage, nothing about their family, to very complex multi-generational families. And people from those families come to the health system to either get care to maintain health and wellness, or to get to health and wellness and maintain it, or for addressing signs and symptoms of medical conditions. And the idea then is that they learn their basic sciences in the context of these rich cases, and then they go to a family physician's office at least one afternoon a week, probably 2 during the second year, and the family physician, depending upon the area of study at the time, attempts to match patients in the broad scheme, not any specific patient on a specific day, but the student's experience with patients that are representative of the area that they're trying to study at the time. So we have a strong connection between those foundational sciences, including the social sciences, and their clinical experience. And by basing the students, by providing the early clinical experience in the family physician's office, they have a sense, I'll talk about this a little more in detail, to really work with the members of the healthcare team and understand what their skill set and scope of practice is. So conceptually, what we're after is the formal knowledge courses and so on are actually embedded in clinical experience, both real and virtual, and creating an environment of inquiry, discovery, and innovation, which requires personal honesty. It requires us to self-assess and admit when we don't have enough information. So how do we integrate? On the first level, and I just talked about this, and that's the patient presentation model. It's used very effectively at Northern Ontario, Calgary, Texas Tech, and other places. And we are learning from our colleagues there, but also growing our own. In addition to that, since the cases offer such a great opportunity, rather than having separate courses in ethics and clinical skills and so on, those courses, although we've, and you'll see the layout, we are integrating all of this skill set within what the students are doing with their cases on a regular basis. So this is another example of integration. So Art of Medicine, where we're talking about professionalism and medical ethics, those concepts are taught within and illustrated within those case presentations I talked about and tested the same way so that students don't make the mistake of thinking, oh, this soft stuff doesn't matter. So it's given proportionally equal weight with the usual biochemistry, physiology, et cetera. There's a course in Society and Community Health. I talked about that before. This is the population health epidemiology, how we do research, how we critically appraise literature, how we apply it in an evidence-based practice fashion. And then the clinical skills, it's not clinical skills, it's clinical skills with a focus initially on communication, both verbal and nonverbal, how do we do motivational interviewing, and then a gradual immersion into the assessment, the physical assessment, and the history taking of a healthy patient, and then through the remainder of the curriculum, patients that present with medical complaints or problems. The initial clinical experience, which is present in most medical schools, as I said, starts literally the second week of medical school and continues throughout the first 2 years, and then leads into a comprehensive community-based clerkship. And then planned interprofessional experiences throughout. So our goal is working with our sister schools and colleges is to create teams of students, so medical students with nursing students, with pharmacy students, et cetera, that are in the community and learning together and understanding better what they all bring to the table and their skill set and their scope of practice. So the main thing here to see is that when you see the colors, those are blocks. So the entire first semester plus is normal. It's how do people present to the system to get healthy, or they are healthy, how do they maintain their health and wellness at various life stages. And they learn all of those foundational sciences in the context of those cases and begin their entry into the conversation about becoming a professional, what are medical ethics and how do they inform what we do, how do I develop initial clinical skill set, and examine lots and lots of normal people so that as they get into the not normal, non-healthy, those findings stand out. So they have a good foundation, a good basis for normal before they enter in. And so the block courses, I don't know what this, anyway, the block courses, where you can see the colors moving across, it's designed so that we can get the students focused on an area of study. But again, vertically integrated, running throughout this are their clinical skills course, so they learn clinical skills, and by the way, anatomy and imaging are fully integrated into the clinical skills course, so that they have 2 years of learning anatomy along with clinical skills. And the same with the Art of Medicine course and the Society and Community Health course. So it's not just, oh, by the way, we want you to understand the epidemiology of disease. They're living it and understanding how it applies to their everyday care of patients. Then in the third year, 32 weeks spent in a rural family medicine practice that is either designated or on its way to a designation as a patient-centered medical home, where there's a team. And there, in addition to working in the practice, the students have a panel of patients, and whenever a member of that panel interacts with the health system, whether they go to the hospital for an admission, a diagnostic study, they go to the cardiologist for a consultation, whatever it may be, rehab, the students follow them through that. So they get to experience our healthcare system through the eyes and experiences of their patients. And then more typical, making sure that we round this out, they have substantial experiences in urban tertiary care centers with inpatient-based medicine, all the high tech. We want to make sure that they have the knowledge to be and the experience to be effective regardless of where they go. So in the first 2 years, as I've outlined, there is a significant longitudinal curriculum in clinical skills, in professionalism and ethics, and in population and community health, integrated, as I mentioned, into the case model that we're using to present the information. In years 3 and 4, again, longitudinal clerkship is that transition, a long transition from what has been more of a classroom-based with substantial clinical experience, a lot of it simulated, into the actual clinical site, and a continuing formal component of the curriculum in all 3 of those longitudinal courses. So that continues throughout years 3 and 4. So this is just pictorially an example of how a week might look for students when they're in the comprehensive community clerkship. So they have 9 half-days planned of patient contact where they're with the healthcare team, taking care of patients in fashion, and then where you see the yellow and the green, they have planned continued curriculum, and it includes the foundation sciences. So it's not 2 years of foundation sciences and out. We continue to work with them to understand why these foundation sciences are important to their practicing of medicine. So how do we build this culture that I've talked about, habits of inquiry and improvement? We need to prepare the learners to attain both routine and adaptive forms of expertise. So we engage them in solving problems in teams. So the entering class will be organized into groups of 8 with a facilitator, a primary care facilitator, and they will be challenged and taught models of how we get data and assess the data and help our patients with solving their medical challenges, their medical problems. And within that context, how we apply research, so best, the proven practices of medicine and the best evidence that's available from the literature. So our focus is on self-directed lifelong learners. That's what SDLLL means. And so that focus, and using a model that was developed by my friend Kelly Skeff at Stanford, creating a model where the students, in working with their teachers, are challenged in a Socratic fashion and modeled how we as mature clinicians address the challenges of not knowing an answer. It's the key part. I mean, it's really easy when it's something that we've done 500 million times and we can answer it, although I'm a little nervous about that because not being in the moment and being automatic is when mistakes happen. But at any rate, at least we need to model for the students what we do when we really don't know an answer. And so I've mentioned obviously the case-based, the rich cases, et cetera, working in the clinical practices, et cetera. And again, the focus on the patient-centered medical home because of its standards. The identity formation, I think, is really critical. It is, as the previous speaker talked about, a very complex environment we live in. And working with patients and their families to make medical decisions, to decide to use resources, et cetera, that are in some cases limited, to make decisions to help do what is the right thing for a patient, which means taking into account the patient's viewpoint and their moral values and so on, and those of the family can be a real challenge. So a lot of formal instruction, again in the context of either real or virtual patients, will help, I believe, with this identity formation. We'll talk a lot about the messages that we send, and we plan within our small group structure the opportunity for the students to come back and share what they observed in their clinical experiences in the community, and to have a chance in a safe environment to discuss what they saw. Because I'm fairly confident that no matter how well we select, all of the role modeling that they receive is not going to be positive role modeling. I'm sure they will see mistakes, and that's okay. I don't expect us to be perfect, but we need to have the opportunity to work with them through some of the things that they see that are perhaps not the best examples of how to practice medicine well. Continuous feedback, continuous assessment is critical. promoting relationships with faculty. We want the students to really get to know the faculty well, to get comfortable with them, to be able to go to the faculty with all of the challenges that they're going to encounter as medical students and then as residents. So again, I sort of like a broken record, but professionalism and ethics are integrated into the curriculum from the first week. There will be practice learning OSCEs, these objectives, simulated clinical exercises will be used as both teaching and assessment opportunities for the students. We're now developing the faculty education program so that we can prepare the faculty to be good role models and to deliver the curriculum in a consistent fashion. The LCME kind of insists on that. It makes sense to me as well. And we will develop a sort of super mentor set of very senior faculty. By the way, if you can't tell, I'm trying to grow up to be Stan, so my hair is getting whiter by the year and it's curly, so someday I'll hopefully be regarded as having wisdom like one of my mentors has. But to really value the wisdom of the experienced clinician, which I don't think we've taken advantage of adequately in our educational system. And lots of feedback, it's really critical. And then looking at the curriculum in driving this process, it's about creating the right culture in the college. So the first thing I did was draft myself. So I'm there, and I've got 3 staff people, and I'm about ready to start hiring associate deans. And in those final interviews to hire the associate deans, start to think about, we really need to have a shared vision and shared values. Those core values and that vision are going to be critical. And the other thing that started to make me a little nervous is that, so I hired the first handful, and let's assume, which I didn't, but let's assume I get it right, and we start to build a team. Every time we add another person, it changes the team. It brings in new values and new viewpoints. So we kept re-engaging in this conversation. Do we have a shared vision? Do we see things the same way? Can we agree that we're going to process and make decisions based upon a set of core values? And I think it got better, but we've had some casualties along the way because of the issues of fit and agreement on values and so on. But I think that's perhaps one of the most important things we can do, because if the students come in and see inconsistency and they see us not aligned around a shared vision, then our chances of being successful with this, I think, are reduced. So the learning in the first 2 years is team-based, lots of small group, and during the first year, a lot of hand-holding as we gradually transition them into functioning as a team and being able to take a set of clinical data and apply foundational science knowledge and other knowledge and skills to the generation of what a medical problem is and how do we treat that problem. And by the way, the person's not the problem. They're a person in our practice that has a problem, and how do we help them deal with that, so that in the second year they're becoming ever more independent as a team, still facilitated, still lots of checking to make sure that it's going well, but this gradual transition occurring in that classroom environment. And then in years 3 and 4 is the basing of the curriculum in the patient-centered medical home model, again with its emphasis on the physician-patient relationship, on the team model of care, so that the students really have the opportunity to experience a very positive clinical culture, if you will. And so among the things that the students will experience is each patient has an ongoing relationship with their physician, their chosen physician, and that physician's team. And the personal physician leads this team of individuals, but like all teams, there are times when the physician hands off the leadership to another member of the team. And the students get to experience that with the team and with the patients. And hopefully, they'll have the opportunity to experience truly coordinated care. When patients need to receive care, not only within that team there, but an expanded team. So we need to bring in the surgeon or the cardiologist or the gastroenterologist. How do we bring that into the patient's care in a systematic, coordinated fashion? So the students experiences the culture of the patient-centered medical home. And each one of the patient-centered medical homes has a shared mission and vision for how their practice will work. And that results in a set of goals and objectives, and they measure. And they measure their success in achieving those goals and are constantly asking themselves, what can we do better and how can we do it better? So the students get to see the application of the continuous improvement science that they learn with us in the practices, and they will, with the clinicians, perform and report on a continuous improvement project within their practice over that longitudinal, those 2 years of the longitudinal experience and the initial clinical experience. They'll get to see the importance of clear roles, how roles overlap among the team members, clear expectations and accountability. After all, this is medicine. We're not talking about going out and playing a game of baseball here, where team is also important, although here I think team is even more important. I talked about CQI. Our model, by the way, is lean, which is based on the Toyota production system for continuous process improvement. They'll get to see how role modeling and leadership work and how leaders flex and become followers when appropriate. And then, of course, obviously evaluation and feedback and rewards and incentives. So I won't spend a lot of time on this, just the team flexes. These are examples of the people that the students will get to work with as a member of the team. And they'll get to see the flexing of leadership, more or less like the orchestra, how we keep things in harmony. And then measurement. So I want to shift because we're getting close to the end. I think everybody's aware that we have a significant issue that's worsening with physician shortage and distribution in our state. The physician shortage is not an equal opportunity shortage. It's more severe among generalist areas of practice like psychiatry and general surgery and family medicine, internal medicine, pediatrics than among our specialties. Although the shortage is global, I don't mean to imply that one thing is more important than another. We're about 1,800 physicians short in Michigan right now. It is, again, a distributional issue. So when you look at the remote and rural areas, the physician supply is 90 to 95 per 100,000 populations versus about 240, 245 in the urban environment. So it really is not, it's really not the same. And so that's really the reason for a medical school in Mount Pleasant, is with 4 excellent, fully functioning medical schools in the state, we have encountered this systems issue with the access to care and doing the same thing and expecting different results. I think everybody knows that's the definition of insanity, so we're trying to do something different. So I'll talk just a little bit about predictors of specialty choice, who goes into rural practice, which is where the shortage is the greatest issue, how do we retain them, and what are we doing at CMU. So indebtedness and lifestyle are 2 huge drivers of specialty choice. If you graduate from medical school, and by the way, the average indebtedness of our students in Michigan, and these are ballpark figures, from MSU is about $185,000, from Wayne State's about $150,000, and from U of M about $125,000. And so that's right along with the national average of about $140,000 in debt at graduation, and 40% of students are more than $200,000 in debt. Last figures available, by the way, are from about 2009, and we should have 2010's figures shortly. So those are important drivers. In addition, they go out in the community and they see general internists like me or family physicians who are just not happy in practice. What does that do for us? Students they're not stupid. They see us, struggling, unhappy in our practice, complaining all the time, churning to just make a living. They won't choose those specialties. So that's the lifestyle issue. Interestingly enough, married female students have a very high propensity to go into family medicine. Public medical schools, more physicians going into the generalist and primary care areas of practice. Where there's a primary care track offered and students get to experience a primary care, either the student track or a primary care residency track, that tends to move more students into primary care and generalist areas. And where the training actually occurs in the community. So not just in big city hospitals, in the community, in practices. Rural practice, this is a shocker. People that are born in rural areas tend to go back there. I know that probably surprises you. Students that express an interest in serving the underserved do have a higher tendency to go rural if they express an interest in serving minorities. Public medical schools, again, males greater than females. That one surprised me, I have to say. It's not a huge difference, but it's about a 5 percentage point difference. Students that come in with an intended career plan of family medicine have a tendency to go to rural areas. Again, the training in the community and the final training location. So if they train in an area that offers rural opportunities during residency, that tends to tip them in favor of going into the practice in those areas. Training in small towns and rural communities has been shown to, and again, there's not a lot of this going on, but it has been effective. And folks training in the primary care, more general areas are more likely to go rural. Public medical schools, focus on primary care, role models, again, the key, positive role models in those areas. So I've talked a bit about the criticality, but we face a worsening physician shortage and distributional issue. It's been predicted that about 1/3 of current Michigan physicians will retire by 2020. So that's 8 more years. So that's not going to help us with the physician shortage and distribution. And it's not going to help our patients' challenges with access to care. So we've located the college. Now, people will tell you that Mount Pleasant's a city. It is the population in the last census was 27,000. And if you go 15 feet outside of any of the borders of the city, you're in cornfields, soybean fields, sugar beet fields. So it's pretty rural. The other challenge, of course, is remote places like Beale City and Clare and Wademan and so on. But by intentionally locating ourselves closer to where the need is, and then creating partnerships with all of the small community hospitals, including the critical access hospitals, and with the federally qualified health centers and the rural health centers, we hope to be able to generate a more distributed model of both student and resident education and really get the students and the residents interested and engaged in the communities. And that'll give us, I think, the greatest opportunity for retaining them. We're using a holistic admissions process. We think we know pretty well what academic qualifications the students need to have, so we can make a cut point and then get into a very rich conversation with the students about how they view life and community. So they'll be writing us essays, we'll be looking at their personal statements, their letters of recommendation. We really intend to value those. They're not always used. And then bring the students to campus for a multi-station mini interview process where we get to explore with them with 10-minute stations their viewpoints about different aspects of medicine that we think and community that we think are really important. The curriculum, again, a fully engaged curriculum that starts out clinically rich and stays clinically rich throughout. Very careful selection and preparation of the teachers and mentors, as well as the training sites. Controlling debt. So we have raised so far about $8.5 million that will endow scholarships. And in addition, we're taking 10% of our tuition dollars and mining those back in for the most needy students. And all scholarships, at least at this point, my view is all of our scholarships will be needs-based. So we want to try to limit, if we can, as much as possible the indebtedness of the students. And then finally, in partnership with Wayne State University and now Western's coming in, is an area health education center that gives us reach into the communities to help the communities develop programs to identify students who would qualify for and be interested in a career in healthcare, not just medical school, but in healthcare, and work with them on enrichment programs, improving the education that occurs in the schools, creating academies, et cetera, so that we can literally create a pipeline of kids from our small communities into college and into the health professions schools and medical schools, and hence have a richer, more diverse group of students that hopefully will go back and practice in the rural communities. And I will stop there.